We'll move further very fast. So this is the landscape. We need to spend like around 30 seconds on this. Cisplatin is a most active chemotherapy in the metastatic urothelial cancer, and it is a sheet anchor drug since 1980s. When the chemotherapy was developed in a very slower manner, and then after 12 years, then next combo has come with some other platinum agents. And with the 25 years of the gap in 2017, there is a development in the this era, and the pembrolizumab and cisplatin were developed in the combination. Then maintenance avelumab after induction of platinum-based chemotherapy, it has approved in 2020, and that make a some noise in this area. When maintenance avelumab could increase the PFS as well as OS. Then checkmate 901 has come, where the GemCis, our favorite molecule, were combined with the nivolumab, and it has improved somehow PFS. And then again, this is the blockbuster drug EV 302 trial, where the enfortumab vedotin plus pembrolizumab has made some good survival advantage. Next, please. In 2023, and we all discussed this trial also. So Javelin Bladder 100, where it was a phase 3 randomized open label study, and the patient population was unresectable locally advanced or metastatic urothelial cancer with having the measurable disease, and they were in the stage 4 disease. They received standard first-line chemotherapy with the GEM-N6 or GEM or Carbo, and the therapy number of the cycle were 4 to 6. The patient got the response after 4 cycles, then they converted into the avelumab maintenance, and if patient could receive 6 cycles, it was fine. So the treatment-free interval was given 4 to 10 weeks after completion of the chemotherapy, but they didn't take the patient who had progressed over the platinum-based chemotherapy, because they were knowing like they are the worst subset of the patient which will not respond to the immunotherapy. So the patient were stratified according to the patient with CR/PR or stable disease, and they screened 700 patients, and out of them 358 patients, almost 50% of the patients were positive for the PDL1 positivity. Then they were randomized into 2 arms, avelumab 10 mg per kg, Q2 weekly plus best supportive care and best supportive care alone. And the drug was given till the progression. So primary endpoint of this particular trial was overall survival, and the secondary endpoint or the secondary endpoint was the PFS, overall response rate, time to response, and response duration. Next, please. So you see the median overall survival from start of the first line chemotherapy. It is not from the starting of the maintenance therapy. They measured the starting from the first line chemotherapy with full Javelin bladder regimen. It was given for the 30 month and setting a benchmark for current and future trials. So you can see if you give the avelumab maintenance, then patient's median overall survival was 29.7 months. And here, if you don't give and only best supportive care was offered, then it was 20.5 months. So there is almost clear-cut 9 month survival benefit was there. And it was statistically significant. HR ratio was 0.77, which seems like it is not impressive, not very much impressive, but it was significant. Next, please. So avelumab maintenance more than double the PFS as compared to the best supportive care. You could see if you give avelumab plus best supportive care, the PFS was 5.5. If you don't give and the best supportive care was offered, then patient will progress in 2.1 month only. And the HR ratio for the PFS was 0.54. So there was 46% benefit in risk reduction of the disease progression or death. And this is the survival PFS curve. You can see the avelumab arm does better than the only best supportive care arm. Next, please. So this is, you can see the comparison between two regimen. Patient had cis-gem or carbo-gem, but still avelumab maintenance does better in both the ways as compared to the best supportive care. But you can numerically see like cisplatin arm did better than the carbo-gem arm. And we know like carboplatin in the area of the urinary bladder cancer, it is weaker drug than the cisplatin, and this has been again reiterated. So OS benefit with maintenance avelumab seen from start of the first line chemotherapy regardless of the chemotherapy regimen, and the benefit was seen in the both type of the regimen. Next, please. So avelumab maintenance extended overall survival in all eligible patients, irrespective of the best response with the chemotherapy. So patient were taken like patient had complete response, partial response, and stable disease. But as we all know, if patient had a complete response, then they tend to do better than the patient who had the stable disease only. and this fact has been depicted in all the Kaplan-Meier curve. You can see patient had a complete response after the 4 cycle or 6 cycle of the chemotherapy. Then overall survival was 39.8 months, almost 40 months. And as compared to the best supportive care, it was 26.8 months, and the HR ratio was 0.72. If patient had partial response, this further overall survival was dropped down to the 9.2 months as compared to the 12.8 months in the best supportive care arm, and the HR ratio was 0.70. The avelumab arm was better, and in patient has a stable disease, then the overall survival has further reduced to 20.3 versus 14.0 months, and it was HR ratio was 0.84. So the it is not that much impressive as that it is in the complete response arm, but still all the three subgroup had maintained the avelumab maintenance benefit. Next, please. So overall survival benefit was observed irrespective of the number of first-line chemotherapy cycles prior to avelumab maintenance. If you give after 4 cycles, or if it doesn't matter, or if you give after 6 cycles. So if you give after 4 cycles, overall survival was 19.9 months versus 13.7 months in the best supportive care. Here, if you could complete 6 cycles and have the response, then it was 24 months as compared to the best supportive care where it was 14 months. Hazard ratio was almost similar, 0.69 and 0.66. Next, please. So median PFS of 26.7 months in patient on available maintenance for more than 12 months. So if you could deliver the drug for more than 12 months, then almost you have win the battle, because the median PFS is great and overall survival also better. So if you give 12 months here, if you complete this 12-month maintenance, then patient will have the progression after, most of the patient will have the progression after 26.7 months. Next, please. And if you give 12 months of the maintenance, then median overall survival was 4 years, which is unforeseen in the metastatic or unresectable urinary bladder cancer, which seems, or which we all accept that it is a lethal kind of the disease. But if you could complete 12 months of the maintenance, then median overs has not reached, and it is more than 4 years, which is very impressive. Next, please. In the Asian subgroup also, they represent 21% of the original trial population, and they all maintain the this various parameters. Next, please. Next, yeah, Asian patients show similar median overall survival benefit as that of the overall patient population. So at the 24-month, you can say 60.7% patient they were survived, and in the best supportive care it was 43.5 months. For 43.5% of the patient were surviving at the 24-month of the cutoff. And you can see the 3 times higher PFS compared to the non-available maintenance. If you don't give any maintenance, only best supportive care, then Asian patient had shown overall survival was PFS was 1.9 months, versus if you give maintenance, then they could progress after 5.6 months. Next, please. These are the common toxicities of the immunotherapy, which we all know. Uh, Pruritus or skin reactions, hypothyroidism are the most common. Diarrhea, infusion-related reaction, asthenia, fatigue. These are the common reactions which we all know nowadays. Next, please. So the efficacy of the avelumab first-line maintenance has been confirmed in real-world heterogeneous population, and they have the data of more than 1,200 patients. So if you have the data of Javelin bladder 100, so 71.3% patient could survive 12 months. If you have the Evans data 65.4, then patient ready data is 69.2 months. The median PFS was 5.5 months in the Javelin bladder 100. Evans trial it was 5.7, and Ready trial it was 8.1 month. And median overall survival in Javelin bladder was 29.7. Evans trial it was 26.7. Ready trial it has not been reached to 50% level. Next, please. So this is the Evans study design. We can skip that. Next, please. Now again, they are seeing unprecedented 40.8-month overall survival with one of the largest real-world study, which was the Evans study. If patient has received first-line platinum-based doublet and had CRPR and a stable disease, and available maintenance was given, so then patient, you can see 1 year overall survival was 97%, and 2 year 81% patient were alive. And if you can use somehow N4 vedotin, then 40.8 8 months was the median overall survival. More than 3 years. Next, please. It is the comparative, you can see the other combinations also prevailing in this arena. Nivolumab plus gemcitabine and cisplatin versus gemcis alone for previously untreated, unresectable or metastatic urothelial cancer in the phase 3 Checkmate 901 trial. Next, please. It is important combination, but somehow in this slide, it looks like it is not important. Key inclusion criteria was more than 18 years of the patient, same patient population. It is previously untreated, unresectable or metastatic urothelial cancer involving renal pelvis, ureter, bladder, or urethra. Cisplatin eligible patient they have taken up and PS021, which is very standard for the international trials. And you can see the combination phase when the GemCis was given with the nivolumab. Nivolumab was given in quite a high dose, 360 mg on day 1, and the cisplatin was 70 mg per meter square day one only, and gemcitabine 1000 mg per meter square day 1 and day 8. Q3 weekly was given up to 6 cycle, then it was stopped and Neo was continued as the maintenance, and maintenance dose was 480 mg Q4 weekly until progression, unacceptable toxicity withdrawal, or up to 24 months. And it was compared with the very standard arm GMNCs for the 6 cycles. And primary endpoint was the overall survival PFS and PFS by BICR. Second endpoint was OS, and exploratory endpoints for overall survival. Next, please. So you just see, if you use the combination of the GMCs at the 12 month, if you use only GMCs, it was 21.8% patient will not progress, and 2% patient, 34.2% patient will be having without progression at the 12 month. 24 month, you can see 23.5% patient will not have the progression, and here 9.6 month. So the Nivo plus GC have the better than the GC alone. Next, please. James is 7.6 month has the PFS, Nivo 7.9 month. But you see the trick is they have compared in the first 6 months only. But if you go further down, then the curve will separate further. Next, please. And you see the p-value is 0.007. OS primary endpoint, overall survival, it is better in the Nivo Gemcis arm rather than the Gemcis. And the p-value is significant, which is the test of the trial 0.017. Next, please. Gemcis 18.9 month, and Nivo plus CIS was 21.7 month. 2.8 month the median overall survival, but whatever it is, it was significant. Next. Subsequent therapies, it is always the question of the international trial. If you have used in this maintenance avelumab, what will you will give in the next progression? So subsequent immunotherapy received before PD, subsequent immunotherapy received at any time. So uses of the avelumab, I will read the last line. Properties of proportion of the patient receiving subsequent surgery, radiotherapy, and or platinum-based chemotherapy were similar in the Nivo GC or GC arm. Next, please. This is the important study, and it is very much highlighted in this last year. EV302 or Keynote A39, where the two different drug companies' drug were combined together. And it was an open label randomized phase 3 study of N4 vedotin in combination with pembro versus chemotherapy in previously untreated locally advanced metastatic urothelial cancer. So we'll see what happens. And next, please. So if you don't consider the cost of this EV drug, EV, and you could give this EV plus pembro, then only concentration of having the side effect with the EV. Otherwise, every measurable point is better with the EV pembro. So let's see what was the design. Patient population previously untreated locally advanced or metastatic urothelial cancer eligible for the platinum, EV, and pembrolizumab, PD-L1 inhibitor naive patient, and GFR more than 30 because they have given cisplatinum, ECOG PS less than 2. So they randomized into 1:1 patient, and the total population was 886 individuals. EV plus pembro, no maximum treatment cycle for EV, and they were used in the maintenance also till the patient can tolerate the EV. And maximum pembrolizumab cycle were given for 35 cycles. So, and it was compared with the cis or carbo plus gem. Maximum 35 cycles was given of the pembro. So AV 302 study, more than 78% patient had CR, PR or stable disease. And you could see in this down, you can say table, the CR rate in this novel combination was almost 30%, which generally is everyone will be surprised in the urothelial cancer to the metastatic or unresectable tumor. And partial response was 38.7, stable disease was 18.18. You see the two-sided p-value was highly significant. It was 0.4 times 0 and then 1. So overall response rate was 67% in the EV plus pembro versus the chemotherapy. Next, please. So it is a far-fetched dream to have this drug EV in recent future, but whenever it is available and we could see how better we can give this drug with controlled side effect will be there. So this combination may be the standard of care. So risk of the death was reduced by 53% in patient who received the EV plus pembro. And you can see at the 12-month cutoff, 78.2%, almost 80% patient were surviving with the Evo pembro as compared to the chemotherapy arm. It was 61.4, and further you see the graph is going wider and wider, and the median survival follow-up was 17.2 months. Next, please. So this is the soaring point of the study. Skin reaction was happened in 66.8% of the patient, because EV also causes, pembro also causes. Peripheral neuropathy was there in 63.2% with the EV. We don't see peripheral neuropathy with the pembrolizumab. Ocular disorder were there, hyperglycemia, which is very troubling side effect, infusion-related reaction 2.0%. Peripheral neuropathy and ocular disorder monitoring is required. Any grade of alopecia, one in out of 3 patients. India is diabetic capital of the world. Hyperglycemia monitoring will be more crucial. Next, please. Yeah, so this is the now how we should go about this particular cancer. So overall survival, first line avelumab maintenance therapy, and second line EV leads to higher overall survival. And sometime later they will say if you use EV in first line, then it is more better. So this is TechMed 901 cis eligible only, Evo GC 7.9 month, and if you can survival time after first line therapy 13.8 month, total is 21.7 month. JB Javelin bladder, where you can use the platinum based combination, then you can use the maintenance therapy, then it is 29.7 month overall survival. If you use avelumab in the GemCis treated patient, then it is 31 month. EV plus pembro 12.5, and it is 31.5. Evans study showed you can use the drug afterwards also, and it is 40.8 month in the real world scenario. It is a cross trial comparison also. Next, please. So this is summary and take home message. Avelumab maintenance more than doubled the PFS compared to the best supportive care, and this is in the unresectable metastatic urothelial cancer, which is by virtue it is a very lethal disease, very troubling, very symptomatic. Avelumab maintenance prolonged overall survival irrespective of the first line cisplatin based combination chemotherapy, whether you use cisplatin or carboplatin, both have the better overall survival. Avelumab maintenance extended overall survival in all eligible patients, irrespective of the best response with chemotherapy, whether it is CR, PR, or stable disease. In Javelin Bladder 100, avelumab first-line maintenance had a manageable safety and tolerability profile with the low discontinuation rate. Real-world evidence of the consistent and efficacy and safety seen in the JB 100. Nevo plus GC, although a positive study, but result in a very minor increment in the PFS or overall survival, which you and may also disagree because it also works better. Pembro plus AV data looks good, but they have not compared in the standard of care, and one needs to be cautious with the toxicity profile of the AV, and especially in the combination also. And finally, sequencing of available option is the key. EV after first and avelumab maintenance resulted in the unprecedented overall survival of the 40.8 month in this kind of the lethal disease. So next. So thank you very much. And if any question, I would be happy to answer.
Yeah. Thank you, Aseem bhai. And just want to ask, are you using routine
Avelumab
this
maintenance.
avelumab maintenance?
Yes,
Yeah.
yes.
So in each and every
Whosoever
case
is
of,
supported by the empanelment, we use this.
okay,
And it
okay.
is not available in RGHS, so most of the chunk patient are just out. But in the other empaneled thing we are using.
So just muscle invasive patient comes to you in your OPD and NACT was given. The 4-cycle cis gem was given, and there is the very good response. And patient is not willing for radical cystectomy. Then what is the next option?
Then you will give CTRT.
If still he is not willing for CTRT, then avelumab can be given as a maintenance in that scenario.
No, if he is not willing for the curative treatment, then he might not be willing for the NACT also then.
No, suppose some patient can take the photo.
Then nobody knows, because if the gross tumor is there, what happens with this kind of the chemotherapy? Though they say like the CR rate was there, but very rarely we could see like CR is there. And they ask for the data also before approving the drug, so we can't produce the data for the NACT followed by the avelumab maintenance,
In last week,
even if they got the radiological CR.
I have seen 2 patients, but they are not willing for surgery and they are not willing for CTRT. Then what next? So I am confused.
But avelumab is not a cheap drug to use without the permission of the authorities.
Yeah.
It's quite a costly drug. So then you can
So,
complete with another 3-4 cycles, which you have left with the NACT, and then
okay.
give some chemotherapy maintenance.
Okay. Sir, is there any thought?
Humani sir, आपसे पूछ रहे हैं.
हाँ.
No. I mean, difficult to answer this question
Yes.
because of the cost, side effect, and the legality. So probably give the treatment-free period to the patient and watch and wait.
Okay. So we will, sir, actually the patient is 80 years, 82 years patient. We have given the 4-cycle of NACT. Now they are not willing for CTRT or suppose some sorts of this surgery. Then what next? So little bit confusion in my mind.
No, but
First, leave
Dr.
the
Devesh, the treatment is decided upfront when they were
Okay.
presented in the tumor board or something. Some surgeon had seen. If they denied there, then there is no point in giving NACT also. It is
Okay.
palliative then.
Acha, we will continue in the palliative settings.
Mm.
So with this avelumab maintenance, so what times you have expend 2 years, 3 years the maintenance treatment in your practice?
No patient has completed till 12 months.
Okay, so there is early recurrences in spite of this maintenance treatment.
No, they have not recovered. One patient died, but other have not you can see the recovered or progressed, but they have not completed.
So maximum time you have gained 11 months, approximately 12 months.
No, they are still alive.
Okay.
They are on treatment actually.
Okay. So, sir, any thoughts about this metastatic urothelial cancer?
Almost no experience.
Yeah. So thank you, Aseem bhai, for this talk.